this week on the BackTable podcast.
The take-home message really is that for those starting out, it's really important that you collect data, you audit your results, and you publish it, because we're going to follow the way of PAE. That's what we need. If we're going to get into the guidelines, if we're going to get NICE approval, if we're going to get into the orthopedic guidelines, then we're going to need lots of data and longer-term follow-up, longer-term safety data and efficacy data. So if you're doing GAE, please record it and share it. It's important for the IR community.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the SpineJack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show.
Hello, everyone. Welcome to the BackTable podcast. Today, we've got a great episode lined up. We're going to be discussing the latest trends and maybe some relevant data all around genicular and musculoskeletal embolization with Dr. Mark Little. We've covered this topic in the past. Jafar Golzarian's been on, Ari Isaacson, Sonny Bagla, but it has been a while, and we're due time for an update. Welcome, Mark, to the show.
Thank you. It's a great pleasure to be here. Thank you very much, Aaron, for that kind introduction.
Yeah, it was great. I had the pleasure of going to Guest MSK again this year. It's a great conference for the audience. I know, Mark, you've been there from the beginning, right, at Guest MSK?
Yes, yeah. So I was involved with Jafar and Mark from the first one, and it's grown over the last 2 years. It's a really exciting space to be in, MSK embolotherapy, and I think that's really a testament to the amount of data that's coming online and being able to run such a unique course year on year. Really, it's been great.
Absolutely. I mean, the difference between last year and this year in terms of audience size was incredible. It was like standing room only. And I got to see Oz, Ahmed, and I think that's when you walked up to us when I was talking to Oz. It was a great conference because it's not huge. A lot of people, a lot of time to walk around and talk to people and ask questions. It's very, I think it's a lot more manageable. I mean, Guest is great, but it's huge. This is a very manageable conference, and you learn a ton in the 2 days. It's usually 2 days, right?
Yeah, 2 days. And I think, it's really interactive, and I think it gives IRs a real good opportunity to really delve into specific topics with a great deal of detail. And I think actually, that sort of model is being used more and more this year at ET. We're doing a sort of deep dive sessions where we can have more time dedicated for specific topics. Again, at ET, we're going to be looking at MSK and have some opportunity to have some, smaller group teaching so that interventional radiologists who may have had some sort of basic experience or just about to start that in their practice has some opportunity to ask us more about specifics of anatomy, technique, kit, which you can't really do if you're doing sort of large lectures, more didactic teaching. So I think it's good, and hopefully more conferences and congresses will adapt that model.
Yeah, and you're right. We are seeing it. I mean, Lorenzo Petrone with his FYA was very much like that. I think it's accelerating and evolving, learning for everybody. So appreciate that. And when I saw you, I was like, hey, we got to have you on the show. And here we are, and we made it. We made it happen.
And I got a hoodie as well.
That's right, exactly. Yeah, it was perfect timing. It's perfect timing. I had one. Yeah,
I know.
But so I like to start these out by just asking, where you're at, what your practice looks like, and then tell us a little bit about the training program that you said you guys have.
So I'm a consultant interventional radiologist working at the Royal Berkshire Hospital in Reading. I've set up a large embolotherapy research group alongside my busy clinical practice. The majority of my workload is embolization. So I do a lot of prostate artery embolization. We're obviously running the Genesis trials, so Genesis 1 and now Genesis 2, which are trials to investigate the role of genicular artery embolization in the treatment of osteoarthritis. And we set up Genesis 1 back in 2018. That was a cohort study, feasibility study, looking at really the technique. Can we perform GAE? Is it safe? And give us some indication of efficacy. And then Genesis 2, which is ongoing, is a large randomized controlled trial, which I'm sure we'll talk about in more detail, trying to tease out the true efficacy with regards to considering the placebo effect. I work in a group of 7 full-time consultant interventional radiologists, and we perform everything, so vascular and non-vascular. We do everything in our hospital other than EVAR, so we don't do aortic work and we don't do stroke. So we do pretty much everything else, so liver, lower limb angioplasty, a lot of urology work, etc. So we have a very broad practice and provider dedicated 24/7 on call. We have fellows and registrars who come from the Oxford training scheme, so they rotate through Reading. And at any one time, we'll probably have a senior and a junior trainee. And we've also fortunate enough to have a fellow who's come down from another training program just because of our experience in embolization and the large amount of embolization. We often get approached by external trainees who want to come and train with us, particularly with regards to prostate, which we're doing, sometimes up to 4 or 5 a week PAE. So we're pretty busy with that regard. That's sort of our overview of what we do and where I sit. In terms of the research side of things, I'm fortunate enough to have a dedicated research team of nurses that support the embolotherapy research. And that's been really fundamental, really, in terms of all of the work we've done over the years with regards to PAE, fibrin embolization, and then more recently with the genicular artery embolization. And that group is in collaboration with the University of Reading, where I'm a visiting professor, and we work within the School of Psychology. We've actually got some really interesting research with those links, looking at the role of neuropsychology and neuropsychometric testing in patients undergoing interventional radiology procedures. And we're using that a great deal recently with regards to GAE and chronic musculoskeletal pain, because clearly with MSK and any condition that pain predominates, we need to think about the impact of the brain and how we process pain. It's a really interesting and complex area. Clearly, one person's pleasure is another person's pain. And so if we try and understand the processing of pain, it can give us a better understanding as to the outcomes following particular interventions. And specifically with regards to GAE, we look into the data surrounding genicular artery embolization. Obviously, from the current literature, there's a great deal of excitement around the non-controlled data showing around a sort of 60% benefit with regards to GAE in terms of improvements of pain and function. But from the recent randomized trials, it's not been as clear-cut. And I think that's really where we need to spend a lot of our time trying to consider this notion of the neural knee axis and where placebo fits in and where neuropsychology fits in. So that's kind of a brief précis of practice and what we're up to at the moment.
Remind me, Mark, how long did you say you were in practice for?
So I've been at Reading for almost 7 years.
We all we do IR, you do IR training, and then we all kind of find these areas where we're super interested, right? Some people go down the PAD route. Some people don't go down the portal hypertension route. Clearly, you're very passionate about embolization procedures. What sparked that for you? Like, what is it about embolization procedure that makes you really wake up in the morning and run to work?
It's a good question, actually. And it all started, I trained in Oxford, did 6 years there, was a fellow there. And I worked with a chap called Dr. Phil Boardman, and he was doing lots and lots of embolization. And we spent a lot of time together doing CERT, so within the liver. And I kind of got the bug, really. I loved the complexity of the anatomy. I loved the fact that it was difficult and you could spend hours and hours just twiddling, trying to get into these small vessels. And I really liked the way in which Dr. Boardman approached it, his finesse and technique and the fact that every movement had a reason behind it. And I quite liked that. I really wanted to get into the sort of granular detail and become good at, a specific task. And, embolization, it can be technically challenging. It's got the intricacies of anatomy with regards to anastomoses, with regards to flow dynamics and change in flow depending on what's happening. And so from that perspective, I thought, well, this is the area for me, really. I just found it more cerebrally engaging than some of the other aspects of IR. And so I sort of then thought, well, I'm going to try and dedicate most of my training towards that and build up a body of research within that. And that's what we were able to do in Oxford with some of the early prostate trials. And that got me hooked, really. I was very fortunate to go to Lisbon and train under Professor Pisco and the group in Lisbon at the very beginning of PAE. And so that was sort of all of these, it was sort of right place, right time, really. It was a juncture where people had been doing fibroid embolization for years and years, and prostate came online. And really, I think since prostate, embolization and embotherapy is sort of, gone stratospheric, particularly within the MSK domain. So I was very much, as I say, in the right place at the right time, surrounded by good people. So it's very much standing on the shoulders of giants.
Yeah. Yeah, I mean, I agree with you. I think embolizations are some of my favorite procedures, especially in the setting of like trauma and GI bleeds, just shutting down those vessels and very quick, results. I first got exposed to GAE was when I was very young attending, maybe a couple years out. I came in on a Monday, and one of the older attendings at the hospital I worked at said, "Hey, you have a GAE on the schedule, by the way." And I was like, "Oh, what?" And this is before all of this came out. It was for hemarthrosis, for an orthopedic surgeon who believed in this for hemarthrosis post TKA. And I had never heard of it before. I had never done it before. He kind of walked me through how to do it. I found it very interesting and engaging, and followed up with the orthopod on, afterwards to find out what the results were. The hemarthrosis stopped, and I was like, wow, this is really interesting and cool. And so I only got to do that 2 or 3 times at that hospital. But then, fast forward, here we are today, and we're using it in the setting of knee osteoarthritis. And I wanted to ask you, just for the uninitiated, because we do have some trainees in the audience, some young people who are just learning about this. Can you tell us about, knee osteoarthritis, the disease process, the prevalence, and how these patients are typically presenting in your practice?
Yeah, sure. And I think, your point about hemarthrosis, to just go back a step, is well made. I think it's a brilliant procedure for hemarthrosis, and, can be really life-changing. In fact, I operated on an orthopedic surgeon who'd had his knee replaced and was having recurrent hemarthrosis and problems. And so it just shows you that, when you're intervening on the orthopedic surgeons, there has to be something in it. So I think it's a great procedure. And I think for anyone that's trying to get involved in GA, it's also a very good place to start. So I think hemarthrosis is a bit more forgiving than osteoarthritis. The vessels are often slightly bigger. The amount of synovitis and target for embolization is often bigger and more obvious. So you can be a bit more aggressive and get away with things. So I think, for anyone listening, that would be a good place to start if you can get involved in patients with hemarthrosis. With regards to OA knee, obviously it's a big problem, and it affects millions and millions of patients worldwide. And the net spend in terms of healthcare costs is huge, billions of dollars a year in the US. And so when we try and understand what the disease process is and what's happening with these patients, that's really where, Yuji Okunu, who's very much the father of modern MSK embolotherapy, sort of identified a potential area to exploit. So there's been a lot of studies which have shown that abnormal neovessels predominate within the osteoarthritic joint, and these new abnormal blood vessels, they release cell messengers, so chemokines, cytokines, and these messengers are involved in creating inflammation. So if you go back to your medical school days, your interleukins and your tumor necrosis factors, these are all bubbling around in the knee joint and causing inflammation and pain, and they're released by these abnormal blood vessels that occur within the synovium and joint margins of the osteoarthritic knee. So the theory, the exploitation of that really is that by potentially blocking these abnormal blood vessels, we can prevent the release of these chemokines, cytokines, and prevent or minimize inflammation, and therefore get rid of the patient's pain. There's also some school of thought around the fact that it may pause the disease process. So there's some experimental work looking at the role again of this sort of inflammatory soup, which degrades the chondrocytes, and can blocking the blood vessels through embolization actually pause the disease process in addition to getting rid or reducing the patient's pain. Within osteoarthritis, obviously, it's a spectrum. You've got patients who've got mild disease who, get along and, they can bob along with a bit of simple analgesia or maybe some physiotherapy. And as the disease progresses, obviously, the pain will increase and the impact on function and quality of life gets worse. So genicular artery embolization is kind of badged for those patients that have failed conservative treatments. So they might have had a steroid injection, they might have had some physiotherapy, some analgesia, but they've failed that and they've still got pain and they're still struggling, but they're not yet candidates for surgery. So the surgeons don't necessarily want to do a knee replacement on them. And the reason for that may be several-fold. Firstly, they might be too young. So, I see a lot of patients in my practice in their late 40s, early 50s who are sportsmen and women who want to get back to being active. But the orthopedic surgeons say, well, I'm not going to operate on someone who's 45, 50 because, I don't want to do a redo knee replacement. So they are an emerging population that we can potentially help. You've then got patients who are not fit for knee replacement surgery for whatever reason, whether it's comorbidities. And again, those patients are challenging to treat because they may still have marked symptoms, but again, they may not be suitable surgical candidates. So genicular artery embolization has the potential to also help that patient group. So to my mind, and what we see in clinic are those patients with mild to moderate knee osteoarthritis that have failed a trial of conservative therapy but are not yet surgical candidates. And when I say mild to moderate, we're kind of appraising that on the x-rays. And if we look at the literature, and it's a bit heterogeneous, actually. There are some studies that have taken on board those with really severe OA and got a response. I'm thinking of Sid Pardier's work in UCLA. There's others such as the group from South Korea, Lee's group, which have found that actually they didn't have a very good outcome, and that those with Kelliger and Lawrence 4, so bone-on-bone severe disease, they actually had a worse outcome from GAE. So bit of work to be done around that.
Interesting. And how are you guys getting referrals in your practice?
So that's an interesting question. So we started in 2018, and initially they were pretty much 90% from our orthopedic surgeons. The way in which referrals for osteoarthritis has changed locally is actually the majority of these patients are now being assessed within musculoskeletal hubs. So they're assessed by a physiotherapist, and the physiotherapist then decides where they should go. So should they see an orthopedic surgeon? Should they have physiotherapy? Or can they be managed within general practice by their family physician? And so we're now getting a lot more referrals from that pathway, from the MSK hubs, from physiotherapists. We get a few directly from general practitioners, and we also get direct referrals from patients as well. Obviously, as the practice has grown, word of mouth. So we sometimes get emails and calls directly from patients saying, we've heard about this. Our friends had their knee done, had a good outcome. Where can I sign up? So that's kind of the referral pathways.
Yeah. And when I think of GAE and the relationship with orthopedics and even primary care docs, you can't help thinking about PAE and the relationship with urologists, or, UFI and relationship with OBGYNs, and how you get those referrals, how you have this conversation with the referring docs, that kind of, GAE is still relatively new. So do you find yourself having to convince any orthopedics, like with data, for those that are kind of looking to start their practice or get those referral patterns going? Are there studies that they can use to, that you can equip them with to go and maybe talk to a hesitant orthopedist or primary care doc? Does that question make sense?
Yeah, no, it does. It does. And I think, the notion of turf war, we're always talking about it in interventional radiology, aren't we? But I think I personally think that this procedure is slightly different, because actually these are patients that are often quite troubling for the orthopedic surgeon, because they'll come back to clinic and once they've offered a steroid or PRP or hyaluronic acid, or if they've not worked, then they're kind of stuck. Where do they go? And it's really then, okay, surgery. And if they don't want to do surgery because they don't want to do a redo challenging knee when the patient's 60, then these patients will be referred to maybe the pain specialists, or see an anaesthetist for some regional blocks and things. So I think from that perspective, actually they're often searching for an answer for these patients. So I don't think it's as direct comparable to, say, PAE or UAE. I also think, like with PAE, those orthopedic surgeons which are the early adopters will see their practice grow. Like the urologists with PAE, I work with a great group of urologists, and they embrace PAE, and the practice grew. And so I think if you're an orthopedic surgeon, I would say that it would be beneficial for the practice overall to look at this, because it's another option for your patient group. With regards to giving details and data, I think data is key. I mean, we need good quality research within this space. I think we did a great job with PAE, which has seen it get into all of the guidelines, AUA recently, obviously, and that's what we need to do with GAE. And I think we're on that trajectory. We've got some good quality studies out there. We've got 2 randomized controlled trials now. I think I would probably direct people to some of the very good systematic reviews or meta-analysis that are out there. Lars Lund's group from Copenhagen has got a nice one. There's a few out there that really summarize the available literature, and the very nice graph of WOMAC or visual analog scale with time, plotting all the different studies. You see that there's actually pretty good data concordance in the fact that if you are a responder, and on average, again, if you look at these systematic reviews, it's about a 60% response rate. That's sort of, I'm being slightly underplaying, but if you look at, on average, 65% response rate in terms of significant improvements in pain and function. And that, I think that's pretty good for a patient population that doesn't really have any other options. The other thing to really discuss is safety and speed of the procedure. Like all embotherapies, there is a learning curve, but actually once you get into it, you can do these cases in an hour, day case, an hour. And, the risk is pretty minimal. I mean, as the generic risk with all our procedures, bleeding, infection, pain, damage to vessels and nerves, which we know are low because that's our job. But the specific risks are obviously the particles we use going into the wrong place. And we do see more often than not, particularly with permanent particles, and we can talk about the different particles perhaps in a moment, but with the permanent particles, we see skin discoloration over the area that's been embolized. And that happens. You get a sort of purplish skin discoloration. It lasts a couple of weeks and then gets better. So there doesn't seem to be any disastrous outcomes that have lasted thus far. So I think that's how I would pitch it, is that actually it's safe. There's promising early data, and actually, within the patient population, if you haven't got many other options, this could potentially be a good adjunct to your treatment strategy.
Right. And even just going back to what we were talking about at the beginning with the hemarthrosis, a lot of the orthopedic docs are already familiar with the procedure because of hemarthrosis and the application. Correct. There. And so it's kind of like they're already familiar with it. And I hear what you're saying, where it's not as competitive as with the you're helping them solve a problem, versus with the urologist, you're really directly competing with the options that they have for PAE. Yes. You know what I mean? Yes, absolutely. I think that's true. Yeah. And kind of the same with GYNs, where hysterectomy is part of their practice, and it's kind of like easy button to push as a solution for fibroids, whereas even though it's been around so long, it's still challenging to have that conversation. Yeah. I think if you look at the data, that the referrals for embolization are actually declining, which I think is crazy. Right. It is for fibroid. It's crazy. But let's not get off on that tangent. Now might be a good time to talk about Genesis 2. You want to talk about that a little bit, since we're just talking about pivotal studies? Okay. Yeah, so Genesis 2 is a large randomized sham-controlled trial. So it's 110 patients, 1-to-1 randomization. So half the group are randomized to GAE,
and we're using 100 micron embazines. Half the group are randomized to a sham procedure, and it is a true sham procedure. So we go into the common femoral artery, we get our catheters down into the genicular arteries, we do runs, we see the hyperemia, and instead of injecting particles, we inject saline, so 0.9% normal saline into the vessels. So it is a true sham procedure. I'm obviously unblinded for safety purposes, but the patient is blinded, as are the clinical team, the research nursing team involved in follow-up. The patients are blinded to 6 months, and at 6 months we unblind. And during that time, we are collecting lots and lots of data, the primary outcome being KOOS, so the knee injury and osteoarthritis symptom score, which is a validated questionnaire throughout a lot of the orthopedic literature on knees, and also within some of the IR literature on GAE. And so what we do at 6 months is we then unblind and say to the patient, look, how's your knee? How are you getting on? And they say, oh, it's terrible. And hopefully I say, well, that's because you had the sham. Would you like the real one? So we do a crossover at that point. So if you've been in the sham, you can then have the GAE. And that's kind of that's the buy-in, isn't it, for this trial? Because initially I designed it that it would be 12-month follow-up, and it would be purely one-to-one, and there would be no crossover. But I think as the data was emerging of it, the cohort studies showing more and more promise of, 65% benefit, it became tricky, not just from an ethical perspective, but also from a recruitment perspective of not having that sort of carrot saying, well, if you get into the trial, the buy-in is you do 6 months, and then if you haven't had the true procedure, you can have it. So that has helped, I think, with recruitment. And then at 6 months, that's our primary endpoint. So we'll be comparing the data from treatment and placebo, and then the sham will cross over, and then we'll follow both groups to 2 years. So that's the study design. And as I say, we're going to collect a lot of data, not just the KOOS, but we're going to do visual analog scale. We're going to look at EQ5D, which is a quality of life questionnaire. We're looking at cost effectiveness analysis, so looking at the economics of this. So it's fully loaded, as well as analgesia and concomitant treatments, as well as safety. So obviously very important to look at the safety as we go along. So yeah, we started that, oh gosh, a year and a half ago now. I think we are halfway through. So it's a complicated trial. There's lots of elements to it. They all get contrast enhanced MRI of the knee beforehand, then at 6 months and at 1 year, to enable us to really assess the impact on synovitis, but also look for complications within the knee joint, like we did for Genesis 1. And then, as I was sort of talking about in my preamble, I'm quite interested about the neuropsychology of things. So as with Genesis 1, we've added into Genesis 2 some experiments to look at that. So they undergo functional magnetic resonance imaging of the brain to look at neural activation and try and correlate areas that are associated with chronic pain with outcome. And they also undergo an assessment of their pain threshold. So we apply a heat stimulus to their arm using a calibrated thermistor and ramp up the temperature and see how they respond. And then we also do some questionnaires, so looking at how their neuropsychology, so looking at depression, catastrophizing, sleep, raft of things, which is very much led by the psychologists within my research group. We're trying to look at lots of different things. I think, from my perspective, it's too simplistic just to say we put some particles in and everything gets better. We need to really think about this in the round and ascertain look at lots of data to try and really understand this procedure and the outcomes of it.
First of all, thank you for explaining that. I'm looking forward to seeing. So the results will be like probably a couple of years from now, it sounds like.
Yeah, we aim to finish recruitment beginning of 25, and then hopefully we'll be pretty soon behind that with regards to getting the data out. You can have a scoop actually for the BackTable, and that we've just had our long-term Genesis 1 data accepted. So that will be published in the next couple of weeks. So that will be, so look out for that. That's going into CVIR, literally hot off the press. So that's our 2-year data for Genesis 1, and it's pretty exciting. So I'm pleased with that paper.
Do you think you'll be presenting that at Guest? It's probably too soon for Guest, huh?
That's going to be at CERSI. So that's we're going to wait. We're going to keep things. We're going to get that out for CERSI. So yeah, that will be the big reveal of all the data for that. But it will be available online and in print, hopefully within a few weeks, depending on how quickly I think Springer do it, how quickly they can move. So yeah, pretty excited about that. And again, some more longer term data for GAE coming online. So that'll be great.
Great, fantastic. And you mentioned embolics. I did want to ask you, what embolic materials are you using, and what all have you tried, and how has that your technique evolved since you started doing this?
Yeah, so Genesis 1, we used 100 to 300 micron embospheres from Merit. Initially, we started with sort of increasing the sort of double diluting, but actually now we just make that up to 22 mils within the vial. So we get rid of the air that it comes in and just dilute down with 100% contrast. And then what we will do is we would decant sort of start maybe about 0.4 mils, load the catheter. It's just slightly more than the dead space of the catheter we use. So we're using a 2 French Pursue microcatheter, and then we would flush that very gently with saline. And that's how we're embolizing. So we're doing it in aliquots of around 0.3, 0.4 mils so that we go nice and slowly, because these are small areas. We want to prune the abnormality, so get rid of the hyperemia but maintain the normal inflow. So that's how we are utilizing and handling the embolic. For Genesis 2, we're using another permanent, but we're using embazines, so 100 micron embazines from Varian. With that, we are making the product up with 10 mils of contrast and 5 mils of saline to get a nice suspension. And again, the delivery is identical. So we will load the catheter dead space, 0.3 to 0.4 mils, and then slowly clear with saline. From there, we will then load again if required and keep going until we've got good pruning of the abnormality, but maintenance of the normal genicular arterial inflow. Obviously, there's a bit of a geographical divide. You probably heard me speak about this at congresses, in the Far East. Yuja Kunu and the groups from South Korea are using temporary embolic agents, so imipenem and cilastatin, which is actually not an embolic agent at all. It's an antibiotic. But when it comes into contact with blood, it produces a temporary embolic agent. So it produces sort of these crystals in a range of sort of 70 microns, and they disappear in a couple of hours. And that's been used in a lot of the MSK territories, not, particularly outside of the knee where, you need a resorbable embolic. The problems with imipenem is that it's not a licensed device and it's an antibiotic. So again, potential issues with regards to antibiotic resistance, etc. So we need dedicated resorbable particles for MSK embolotherapy. There are several that are being looked at. You've got NextSphere by Next Medical, which is recently just got licensed to be distributed in the UK. So that's exciting. So we will have access to a resorbable particle. I'm actually working with a company in Ireland called CramMed. Been doing a lot of research with them on a novel resorbable embolic agent called Securabead. And we've just finished our first in-man trial of that. So that's pretty exciting as well. So I think in time, we will get access to dedicated resorbable embolic agents, and that will open out the MSK space, certainly beyond the knee. As I said, at the moment, we are limited to licensed permanent spheres within the context of our research studies.
Yeah. And then I saw Mark present something on lapio joints, this lapio joint trial. I mean, can you speak on that I don't know if you have tried that technique? I know Oz has tried it.
Yeah, no, we haven't tried it as yet. Again, looks interesting. So he creates an emulsion using Lipiodol and air, I believe, to put in the 3-way tap, and you create sort of a foam emulsion, which is then used to inject into the selected genicular arteries and embolize it. Obviously, we've got the early data from Mark Sapoval's work. It's good. I think, all data is good data at this point. We need to keep exploring the space. I don't think I'd advocate liquids at the moment. I think that would be too proximal and might lead to issues. I think you do need to get out there in terms of the distal genicular arteries. So I think for me, I'm still a believer in the particulate embolotherapy aspect or embolization of things. But, I think we just need to keep going with the data.
Yeah. It's great that there's all these options, right? Well, speaking of, thank you for also explaining your technique. I wanted to talk a little bit about, and I know you spoke about this at Guest MSK, was a little bit about like challenges, especially challenging anatomy, especially given the territory, PAD, right? I mean, I know, a lot of these patients are, middle-aged, but middle-aged, we do, especially in diabetics and people with significant atherosclerotic disease, they got PAD down there. Can you speak a little bit about that? Just in, not just PAD, how you overcome PAD, but also any other anatomic challenges that you've come across?
Yeah, so we've done a lot of work on the anatomy with regards to GAE. Published a paper looking at a study we did looking at cadaveric dissection and the angiographic data. And with regards to the anatomy, it can be complicated, and there's certainly a learning curve when you start. The difficulty with the genicular arteries is there are lots of anastomoses between them. And sometimes that can be great because you can get into the descending genicular artery, get distal, and you can see the superior medial, and you think, okay, great, I'm in this, that's the backdoor territory, so I won't need to then get into that one as well. So you can embolize from a single point. Sometimes, though, you get anastomosis to areas that are slightly less favorable. So it might be a vessel that goes to, say, the medial sural arteries, which are the vessels that supply the tibial nerve, or you'll get an aberrant supply that goes directly into the popliteal artery. So you've got risk of non-target embolization down the leg. So you do need to be familiar with the anatomy. We use cone beam CT on all of our cases as a checkpoint. We did it, very much from the beginning when we started as a safety measure. The way we do that is we actually get into the genicular artery and then we do a spin, 0.3 mils per second, 6-second delay, 6 mils of contrast. And that enables us to actually see if we're going to inject particles next, what's going to happen. So to make sure that we haven't got a big anastomosis that's going to embolize bone, muscle or skin or go down the leg. So that, I think, as a sort of tip, if you've got access to cone beam, that's useful. I know that not all IRs do, particularly those in the OBL setting in the US, which is slightly very different to our setup in the UK. But I think, starting out, that's useful. With regards to peripheral vascular disease, I think it's pretty binary, really. You shouldn't be doing GAE in someone with peripheral arterial disease. And we don't get CTAs up front. What we do is when we see them in clinic, we ask them questions. So has anyone ever told you that you've got problems with the arteries of your lower limb? Do you get any pain in the calf when you walk? So we try and screen it. Do you smoke? Have you ever smoked? If they have, significant smoking history, what I'll do is I'll just take them next door and I'll just whiz the ultrasound down and say, okay, what's going on here? Have they got any calcification in the common femoral artery? What does the popliteal look like? If there's any disease, I'll say, look, this isn't for you. Because I think, as we know from the peripheral vascular disease literature, the genicular arteries are absolutely crucial to providing those bypasses to occlusions. You see it all the time. Popliteal occlusion, the genicular arteries are huge, and they provide this wonderful network to supply the lower limb and prevent you losing your leg. So I would strongly advise that you do not perform GAE on anyone with significant peripheral vascular disease. I think that is a recipe potentially for disaster, particularly where we are with the technology and the technique. And things may change, like all things evolve. But at the moment, I would hate for someone to have a significant complication that puts us on the back foot.
Absolutely. I mean, would you say it's a absolute contraindication? I guess it depends on the level of I think, well, okay, it depends on what you're defining, but I think if a little bit of calcification in the common femoral artery, I mean that's quite common in someone over 70. But if you've got any stenosis that's greater than 50%, within the SFA or popliteal, I would be very, very nervous about intervening on those patients. I really would not, and I've spoken to Sid about this, and I think we're both on the same page. I think it is really an absolute contraindication because these patients down the line, their disease may progress. And if you've taken out the geniculars, even with pruning, you're potentially limiting their ability to provide a bypass, for, as God intended. How are you guys, screening these patients? Because if they're not getting, obviously you're going to do ultrasounds and stuff like that, but diabetes is very common in the United States, and they have small vessel disease. So where do you, what's that cutoff basically, right?
And the prevalence is increasing. I don't screen those patients out. But again, I will ask them as to whether they have, if they say they're, diabetic, I will say, are you under the care of the podiatrist? Have you got any specific issues with your feet? Have you got any skin discoloration of the lower limbs? And again, if they answer yes to those questions, my warning signs are up, and I have to think a lot more carefully about whether they are the right patient to intervene on. So my threshold is pretty high, actually, and I think it can be, because there are so many patients out there. There are lots and lots of patients with mild to moderate osteoarthritis of the knee that are struggling, and lots of middle-aged patients, late 40s, early 50s, where they're up until recently they might have been playing sport, or they want to get back to playing with the kids. You think, well, this is potentially a great option. So I don't think we need to take on these sort of marginal cases or potentially challenging cases, because there's a lot of work out there with the ones that truly absolutely straightforward and can potentially benefit. So yeah, I would set your bar reasonably high with this technique, actually.
Okay, that's great advice. So we've covered a lot with GAE. I did want to cover a little bit of the other exciting MSK embolizations that a lot of research is being done on, and we got to hear a lot about, I guess, MSK, including frozen shoulder, tennis elbow, plantar fasciitis. Yeah. Can you speak on what's on the horizon for other MSK embolizations, and kind of what level of evidence do we have where we're at right now?
Yeah, I think it's super exciting. I think in terms of evidence, really the knee is the only one with any kind of body of evidence behind it. Everything else is sort of small cohort studies, case report stuff. The shoulder is second with regards to data. And we've done some cases looking at shoulder. I proctored a shoulder case actually using the SecuraBead CranMed device recently. And I think, shoulder is really interesting. Again, huge patient population, difficult treatment surgically, really, steroids, but not really much in the way of operatives, so manipulation under anesthesia, etc. But it can be tricky patient groups to treat. There is again a big correlation with diabetes. Thankfully, with regards to the shoulder vasculature, it seemed to be less of an issue. So that patient population seemed to be okay to intervene on, but obviously you have to be mindful that they might have microvascular disease, and it might be more challenging to cannulate those vessels. But there is a direct correlation between diabetes and frozen shoulder, so that you will invariably see that as part of your practice. With regards to shoulder, I think from the data that came out of Spain and France, we probably shouldn't be using permanent spheres. I think that's been proven that actually the risk profile is too great in terms of skin changes over the shoulder. So resorbables, temporary embolic agents are what are required. And Ana Fernandez in Spain, northern Spain, has done a huge amounts of work on this. And she uses imipenem, as does Yuji Kunu, as does many others. But obviously in the UK, we struggle to use that because it's not a licensed embolic. So with regards to other territories, I think plantar fasciitis has the potential to be huge. Again, challenging, not very much in the way of treatment. And we see a lot of runners. I try and run myself sometimes, and it can be really disabling. Plantar fasciitis,
it's the worst.
Yeah,
it's the worst.
Really painful.
You can't walk.
No, absolutely.
It hurts so bad.
Yeah. So, and there's some amazing preliminary data that's come out of the Far East on that. And I think, again, if we can get hold of a dedicated resorbable embolic, and maybe now that we've got NextSphere in the UK, and that's Lice CE marked, so maybe we can start using that and upscale our experience of that. So I think shoulder and plantar fasciitis are the two beyond knee which really shine with me as being potential huge patients to help treat. And then there's some sort of slightly more weird and wonderful is probably the wrong description, but certainly exciting. Hand osteoarthritis, finger osteoarthritis. So I've seen there's some data looking at putting a cannula into the radial artery, and again infusing imipenem, this temporary resorbable embolic, and getting rid of the hyperemia seen within Heberden's nodes for patients with DIP osteoarthritis, which again, incredibly common. And again, there's not really a very good treatment for it. Joint replacement is pretty hopeless for that. Steroid injection lasts for a bit sometimes. So again, potential huge number of patients to help there. But we need data. We need much better data than we've got when we look at these other sort of peripheral indications. And then finally, which is something that is just at the beginning, is looking at chronic back pain, which again, huge problem. But I think there we need to be very careful as to what we're actually trying to treat. We need to understand. I'm very much we need to understand the pathophysiology, what's happening, why embolization has a role, and look at the outcome. I think we need to be very clear on that. So, obviously lots of people get excited and say, oh, we can treat back, but what are you treating? Are you treating the hyperemia within facet joint OA? What are we doing here? So I think people are talking about it. There is, to my knowledge, one paper out there. I just think we need to be a bit cautious because we don't want it to sort of spiral out of control and people just sort of having a go at things and end up in real trouble, particularly in and around, the spine and things. So,
yes,
I think there's enough work and excitement with the territories which do make sense from a pathophysiological perspective, but we just need to proceed as we've done with the knee. We've got some very nice animal data. We've got some good early clinical data. We've now got randomized data. So that body of evidence has been built really nicely over time. I think as long as the other techniques follow that same pattern, then we will potentially be in very, very good shape. But as I say, the main limitation for us in the UK certainly is not having access to a dedicated temporary embolic agent for these other peripheral indications. So I think that's really where certainly my research is focusing on, and I think it's going to be exciting to see what happens in the next couple of years with regards to the data for those indications.
Yeah. Well, Mark, we're coming up on the hour. I mean, any other resources or papers or conference? We've mentioned a number of conferences during this talk, but anything else that you recommend to our audience to get acquainted with MSK embolization besides the guest MSK, which we both been talking about? I know there's a lot of on-demand stuff out there as well, but anything you recommend?
Obviously, I know this is predominantly a US group, but Cersei has a good repository online for anyone who's a Cersei member. They collate the lectures into different repositories. There'll be one for MSK, I'm sure, so that will be a good source to look at. Obviously, we've discussed a number of the conferences, guest, ET. We encourage anyone who's not been to ET to come along to that. That's got a really strong MSK element, which has increased over the last couple of years, and I've helped to facilitate that this year. We've got SIR, I thought was really good. I presented there this year with some very good session, well attended. And obviously throughout the year, there's a number of webinars and things that people can interact and engage with. I think, as I mentioned, if you're sort of starting out, I think a good place to start would be one of the commentary papers or one of the many meta-analysis. And I don't know if they've got show notes, but I'm happy to share some of those references with you. We can put that on for listeners to click on and get to those, because I think they give you a nice broad overview of the technique, what's available, what the current literature has to say, and hopefully inform your practice. For me, the take-home message really is that for those starting out, it's really important that you collect data, you audit your results, and you publish it. Because, if we're going to follow the way of PAE, that's what we need. If we're going to get into the guidelines, if we're going to get NICE approval, if we're going to get into the orthopedic guidelines, then we're going to need lots of data and longer-term follow-up, longer-term safety data, and efficacy data. So if you're doing GAE, please record it and share it. It's important for the IR community.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.